So a 20-year-old man goes in to see his family doctor with some upper abdominal pain, and the family doctor orders a liver ultrasound to look for gallstones. There are no gallstones on the ultrasound, but there's a big liver mass in the left liver that's reported to likely be benign given the patient's age, but they suggest getting a liver MRI because it's big to make sure that it's benign. And so this is the liver MRI in this patient, and you can see that there's this big mass in the left lobe of the liver here, and all of the sequences as part of this MRI are here on the right. And the appearance of this mass on each of these sequences is going to be a piece of the puzzle that helps us figure out what this mass actually is. And what we think this mass is and what we say about the mass is going to determine what happens next. So does this patient need to go to surgery? Do they need a biopsy of the lesion to figure out what it is? Is this benign and requires no further follow-up, or should we be following it up with imaging? So we're going to go through this case in further detail at the end of this video. This introductory video is part of an interactive course that's designed to teach you how to read MRI of the liver. So by interactive, I mean that you'll be able to scroll through full MRI cases that are representative of the most important pathologies that you need to see, and will teach you everything that you need to know about each of these pathologies. The course is split into two parts. So this is the first part, which is an introductory video designed to teach you the basics, specifically what the sequences are in a typical routine liver MRI. We also want to show you what the normal background liver looks like on all of the different sequences and what lesions look like in comparison, aka what you're looking for. And then we'll show you my approach to liver MRI, specifically going through what I use each sequence for when I'm looking at these studies. Then the second part is a series of over 25 carefully selected cases that you can scroll through and take a look at as unknowns. So for example, here we have case 1, and if we click on the case, we have the MRI images pop up with all of the sequences here on the left and all of these standard PACS tools across the top. And you'll notice that there are several lesions here in the liver that require characterization. Each of the cases comes with answers and explanations. So for example, if we click that here, we see that these are a bunch of hemangiomas and cysts, so a very introductory and basic case. And then if we click on this blue square here in the top right, we have an explanation including everything you need to know about the particular pathology, including a walkthrough of imaging findings. So for example, the imaging findings of a classic hemangioma here are outlined. And if you click on the links, it'll take you to those imaging findings. So of course, classic hemangiomas are very T2 hyperintense, and we go through the enhancement pattern here on arterial, portal venous, and delayed phase imaging. We also go through some important pearls on MRI, including some more advanced MRI concepts, as well as the appearance of both typical and atypical hemangiomas on MRI. So for liver MRI, the cases focus on a few key areas, specifically characterizing solid liver lesions, characterizing cystic liver lesions, and the characterization of the background liver, aka looking for diffuse liver diseases. So by the end of the course, you'll have seen all of the things that you need to see on liver MRI and the things that you need to know to be able to interpret liver MRI efficiently and effectively. So this course includes all of the pathologies currently on the screen and more, and can be accessed on our website, navigatingradiology.com, along with our other CT and MRI courses. Okay, so before taking this course, you should already know some MRI basics and anatomy. We cover basic liver anatomy in our CT abdomen and pelvis video, including liver segmental and vascular anatomy. If MRI is new to you, I suggest starting out with our Introduction to Body MRI video. Okay, so let's start with the basics so we can get you working through the liver MRI cases as soon as possible. So let's open up that first case again. So to follow along and scroll through this case, you can use the QR code on the screen to open up the case on your phone, or use the link in the description. So on the left here, we have all of the MRI sequences that are part of this routine liver MRI protocol. And so scrolling through and looking at all these sequences, it can be a little bit overwhelming at first, but if we break it down, it's really not that bad. There are 4 groups that we can put each of these sequences in. And as we go through each sequence, we'll pay special attention to the appearance of the normal liver and what we use each sequence for. So the first group of sequences that we're going to talk about are the T2 weighted sequences. So this is an axial T2 weighted sequence performed with fat suppression. So notice that the subcutaneous fat is all very dark or hypointense. And notice fluid like the CSF here or the fluid in the gallbladder is very bright. Also notice that the liver is relatively hypo-intense on T2 weighted images, so it's pretty dark. Most of the lesions that we see in the liver here, or in most cases, are going to be relatively hyper-intense to background liver, i.e. they're often going to stand out as relatively bright on a dark background in most cases. So in a routine liver protocol, we usually perform T2 weighted sequences in axial and coronal, with at least one of them with fat suppression and one of them without. So notice that this coronal sequence is performed without fat suppression, so the fat is still hyperintense. So sequences with fat suppression like this axial are going to be more sensitive to picking up fluid signal because fluid is relatively bright on a darker blacker background. But we perform sequences with fat suppression to better define the anatomy. So for example, you can see where the liver ends and where the fat starts here. And if I looked at this axial with fat suppression, it's harder to tell, for example, where the liver ends and where the fat starts. So although we cover this in our intro to body MR video, remember that longer TEs are going to make the image more heavily T2 weighted. In other words, as TE gets longer or the echo time gets longer, fluid maintains its signal and stays very bright, and everything else gets darker. So for example, if you look at these first 2 sequences in this particular protocol and we put them side by side, you'll notice that they're both T2 weighted sequences with fat suppression, and they're both performed in the axial plane. But the first here on the left has a TE of 80, and the second here on the right has a TE of 180, or it's longer. So notice that with a longer TE, the fluid maintains its signal here, but everything else gets darker or loses signal. And as I showed earlier in this case, this anterior lesion here is a cyst, and this posterior lesion here is a hemangioma. Notice that on the shorter TE, they have more similar signal, but on the longer TE, the hemangioma has lost some signal relative to the very bright cyst. It's also worth noting, although we're going to discuss biliary imaging in another video, MRCP images are just very heavily T2 weighted images, i.e. they have a very long TE. So you can see the anatomy of the fluid-filled structures very well. So for example, the biliary system, and depending on the protocol, you may also have MRCP images. On our routine liver MRI protocol, we do not. Okay, so we've talked about the first group of sequences, the T2 weighted images. Now let's move on to the T1 weighted images. So again, we cover these in more detail in the body MR intro video, but as a reminder, we performed in and out of phase acquisitions. So here we have the T1 in phase on the right, and then the out of phase here on the left, easily identified by this India ink artifact. So these images can be used to assess for intravoxel fat and susceptibility artifact from things like iron, metal, air, etc. So for example, we can look for fatty liver or iron loading in the background liver or fat content in lesions, for example. So fat in a focal liver lesion, of course, is going to significantly change the differential for the lesion, so it's important to look for. As a reminder, if we compare the in and out of phase images, voxels with both fat and water protons are going to decrease in signal on the out of phase images, hence the India ink artifact at the margins of the organ. So for fatty liver, for example, the liver is going to be darker on the out of phase compared to the in phase sequence. Also remember that the out of phase acquisition is performed first or before the in phase sequence. So when we have susceptibility artifact from something like metal, air, iron, calcification, susceptibility leads to a loss in signal at that site over time. So since in phase is acquired later, these areas will be darker and maybe even larger on the in phase image. So for example, if there was iron loading in the liver would be darker on the in phase than the out of phase. So notice here, for example, on the out of phase, we have some gas here in the colon as expected, and notice how it's darker and larger on the in phase image related to the susceptibility artifact. Okay, and next, from the in and out of phase acquisition, using the Dixon method, we can calculate water only and fat only images. So the water only image is a nice T1 fat suppressed image. Notice that the fat is very nicely suppressed over here on this image on the left. Also notice that the background liver here is actually pretty bright on these T1 weighted images. So most lesions are going to be relatively hypo-intense to background liver, but also things that are very T1 hyper-intense are going to stand out nicely on this T1 weighted fat suppressed sequence. Remember the things that are T1 hyper-intense, most importantly for liver MRI, hemorrhage, melanin, and other proteinaceous material. This image here on the right is the fat-only image, and as a reminder, the fat-only is going to show you both bulk fat and intravoxel fat. So this sequence is helpful to quickly identify fat in lesions and also to look at the bones. So normal fatty marrow is going to be relatively hyper-intense, so marrow-replacing lesions are going to show up as relatively hypo-intense. Okay, so far we've talked about our T2 weighted sequences and our T1 weighted sequences, including the in and out of phase and downstream sequences. So third, and not in order of acquisition, but to logically remember all of the sequences that you need to account for, is our T1 pre and post contrast images, which again is logical. So we're going to give contrast or gadolinium. So we're going to have both pre and post gadolinium images here. So here on the left, we have our axial pre-contrast image, and then gadolinium is given, and we have acquisitions in the late arterial phase, portovenous phase, and delayed phase. We also acquire a delay in the coronal plane that we'll look at in a bit. But notice that all of these are fat suppressed, of course. So in MRI, signal intensity is relative. So if we want gadolinium, which is very T1 hyperintense, to stand out as the brightest thing on the image, then we want to suppress the very bright fat signal so that we can actually see what is enhancing. But let's talk a little bit more about these phases. So first, starting with the late arterial phase, notice that the background liver is still relatively hypo-intense. So hypervascular focal liver lesions are going to stand out as relatively bright on a darker background. Very importantly, the timing of this acquisition in late arterial phase is very important in liver imaging to detect HCC and other hypervascular lesions. So poor timing of the late arterial phase, either too early or too late, can and will lead to missing important lesions like HCC or hepatocellular carcinoma. So how do we know if it's well timed? So in short, a good arterial phase should have of course, opacification of the arteries and the portal vein, but not yet opacification of the hepatic veins. If the portal vein is not yet opacified at all, then it's too early. And if the hepatic veins are already opacified, then it's too late. So this is a key concept that you need to remember when it comes to liver imaging. And for this reason, HCC-specific MRI liver protocols will often acquire more than one arterial phase back to back to increase the chance that we have a well-timed late arterial phase acquisition and have the best chance of detecting hypervascular lesions like HCC. This third image here is the portovenous acquisition. Notice that the portal vein is opacified, but the hepatic veins are also opacified. Also notice that the background liver is now brighter, so hypovascular lesions are going to stand out very well on the portovenous phase as relatively dark on a brighter background. Of course, the enhancement pattern of lesions over time from arterial to portovenous to delay is very important in accurately characterizing liver lesions, just like on CT. Also very important, the delayed coronal acquisition often covers more anatomy than the axial sequences, so it's a great sequence to catch incidental findings in the lungs, in the breasts, in the pelvis or partially imaged pelvis, and in the bones. So you need to look for these things on every case on this coronal post-GAD image. Okay, and lastly, fourth, we have our diffusion weighted images, which again, we covered in greater detail in our introduction to body MRI video. But this includes the DWI acquisitions with multiple B-values. So here is a lower B-value acquisition, aka there's less diffusion weighting. It almost looks like a T2 fat sat or a poor man's T2. Notice that the simple fluid is going to be very bright here. If we keep scrolling, we get the higher B-value acquisition, which is more diffusion weighted. And then from that, we can calculate the ADC. This is what it looks like here on the right. And so things that restrict diffusion should be bright on higher B-value DWI images and darker on ADC. And again, this is covered in greater detail in the body MRI video. So many solid malignancies are going to restrict diffusion. Okay, so with all of these sequences, we've covered quite a bit, but the protocol isn't really as complex as it may seem at first. So again, a typical liver MRI routine protocol includes T2 weighted sequences in the axial and coronal plane, plus minus more heavily T2 weighted sequences with very long TEs like MRCP. We have our T1 weighted sequences, including the in and out of phase with calculated fat only and water only images. We have our pre and post gadolinium T1 weighted images done with fat suppression, and then we have our diffusion weighted images. Okay, so before going through my approach, I want to briefly introduce gadolinium-based contrast agents that we use in liver MRI. So as a practical starting point, you should know the following. So in MRI in general, we most commonly use extracellular contrast agents. And when most people colloquially refer to gadolinium or GAD, they really mean one of these extracellular contrast agents like Gadavist. So these are excreted by the kidneys, and on imaging, they behave very, very similarly to iodine-based contrast agents in CT. So in general, you can apply what you know about IV contrast enhancement patterns from CT to MRI with quote-unquote GAD. So for routine liver imaging, we use these extracellular contrast agents. But there are some circumstances where it's helpful to use a hepatobiliary specific contrast agent called gadazetic acid, trade name Eovist in the US and primovist elsewhere. I'll use primovist because I'm from Toronto, Canada. So primovist is excreted both by the renal and hepatobiliary system, about 50-50. And so early after injection, it behaves like an extracellular contrast agent that you're used to. But over time, the liver cells will take up primovist, mostly due to a transporter called OATP1B3, and then begin to excrete it in the biliary system. So over time, the background liver gets brighter. So the appearance of the liver lesion compared to background liver may be different than with extracellular contrast agents. If we wait 15 to 20 minutes and image, the liver will be very bright, and the biliary system will be even brighter since it's filled with excreted contrast. So this gives rise to the name, the so-called hepatobiliary phase. So notice that the biliary system here on this hepatobiliary phase sequence is very, very bright, and the background liver is also very, very bright. So there are many clinical scenarios where this can be useful and beneficial clinically. And so to name a few common uses, one, to identify metastases. So if the background liver is very bright on hepatobiliary phase because of the primovist uptake, focal metastases and other non-hepatocyte containing lesions are going to be dark. So this is important in certain types of cancers like colorectal cancer, where hepatic metastases can be cut out with curative intent. So we need to identify all of the metastases. Secondly, primovist can help with the characterization of some lesions. So lesions that express OATP1B3 will also take up primovist. The classic example to know for now is FNH, or focal nodular hyperplasia, which will be isointense or hyperintense to background liver on hepatobiliary phase. But there are others that we'll touch on in the course. And then 3, to look at the biliary system. The biliary system is very bright on hepatobiliary phase, as we showed in these images here, which helps define the biliary anatomy and assess the biliary system, including for bile leaks, for example. So if that's all too much for now, just remember that extracellular agents, which are used in the vast majority of cases, behave like iodine-based CT contrast agents. So we can apply the enhancement patterns we know from CT to MRI with these agents. Also, We have the hepatocyte-specific agents like primovist that have certain clinical indications that behave similar to extracellular contrast agents early on, but over time the enhancement patterns can differ from what we expect to see with quote-unquote GAD. So now that we've covered the basics, I'm going to briefly take you through my practical approach to interpreting a liver MRI. Then we'll cover the case of the 20-year-old male patient from the start of the video together. So again, there are a lot of sequences and everyone has their own way of looking at things. I'm going to go through my practical approach for the real world. So step one is to know the history of the patient. So before looking at the images, it's important to know the clinical history because the history completely changes how we interpret the images. Most importantly, one, I want to know, is there a history of known malignancy, which will increase the chance, of course, that there are liver metastases. The type of malignancy is also important. For example, we may expect hypervascular metastases in things like RCC, neuroendocrine tumors, melanoma, etc., and hypovascular metastases with most others, including colorectal. Two, I want to know if the patient is at high risk for HCC. Most importantly, a history of cirrhosis, chronic hepatitis B, or prior HCC. If yes to any of these, we're going to interpret focal lesions in the liver completely differently because the chance a focal lesion is HCC is significantly higher than in someone who does not have these risk factors. And we'll discuss that in detail in the course itself. And then three, any other relevant history, i.e., prior medications like chemotherapy, oral contraceptives, etc., and other relevant systemic disorders. And we'll touch on some of these important things in the relevant cases in the course. Okay, and so step two is to start looking at the images, starting with the background liver. And I start looking at the background liver since, again, the presence of liver disease may change how we interpret focal lesions in the liver. So for example, if we see frank cirrhosis, then we know that the risk of HCC, for example, is higher. So when I'm looking at the background liver, I start by looking at the in and out of phase images. And I'm looking for signal abnormality on the in and out of phase images, so specifically for fat content and iron, i.e. for hepatic steatosis or iron loading in the liver. I'm also looking at the morphology of the liver on these images, including the liver contour, specifically on the out of phase. So notice that the contour is nicely outlined by the India ink artifact. And I'm looking for signs of cirrhosis like lobar redistribution and frank surface nodularity. So for this case, there's no background signal abnormality in the liver. Next, I start looking for focal lesions. So I start by looking at the axial fat-sat T2-weighted images. Again, you'll notice that the normal background liver is pretty dark on the T2-weighted images, and most, but not all, liver lesions are going to be relatively bright compared to the background liver. I should say that anytime in this approach, if I see something abnormal or anything focal, I then look at that lesion on all of the sequences to characterize it further. Specifically, four things. I want to know, what does it look like on precontrast images, aka T1 and T2 weighted images? Does it contain fat? Does it restrict diffusion? And what is the enhancement pattern over time? So for now, I'm going to take you through a general approach, but remember, anytime you see anything focal on any sequence, you want to characterize and know those four things. So once I've looked at the T2 weighted images, a lot of people will go to the T1 and pre and post contrast images, but next I generally jump directly to the diffusion weighted images. And I have a quick look through for any obvious lesions on both the low and high B-value images, specifically looking for any lesions that are restricting diffusion. So diffusion is a great sequence. Certain types of metastases are going to stand out best on the diffusion weighted images and maybe a lot more difficult to see on other sequences. With that being said, there are other malignant lesions that may not be very well seen on diffusion weighted images at all, but I like it a lot because it gives you a quick overview. And the rule of thumb for DWI in the liver is if you see something and it restricts diffusion, that's very helpful. But if you don't see anything on DWI, that doesn't necessarily rule anything out. Again, if you see a focal lesion on these sequences, you want to look at its characteristics on all sequences, the T1 and T2 weighted signal. Does it contain fat? Does it restrict diffusion? And what is the enhancement pattern over time? Lastly, I look at the T1 pre and post contrast images, and the approach to this is somewhat similar to multiphasic CT. On the pre-contrast fat saturated or fat suppressed images, I want to look for focal lesions, including for lesions with intrinsic T1 hyperintensity, which may indicate hemorrhage, proteinaceous material, or melanin. Again, you always want to make sure that the arterial phase is well timed, and then look closely for hypervascular lesions on late arterial phase. This is something that you're going to take your time with, especially if the patient is at high risk for HCC. On portal venous and delayed phases, we're going to be looking for relatively hypovascular lesions. And then once again, of course, if you see any focal lesion anywhere, you want to characterize it again by looking at the T1 and T2 weighted signal pre-contrast, whether it contains fat or susceptibility, whether it restricts diffusion, and then the enhancement pattern over time. And of course, in the liver MRI course, we're going to cover in detail the typical appearance of all of the liver lesions that you need to know. And so then if you know those characteristics, when you see a liver lesion on MRI in real life, you'll be able to note the 4 characteristics that we spoke about and then put the lesion into a box to know what that liver lesion is, or if there's a differential between a couple different types of liver lesions. Of course, after looking at the liver, we're going to look at the structures in the rest of the abdomen, which is all covered in the body MRI intro video with the link to that approach on the screen. And so we'll cover the biliary system, pancreas, other solid organs, etc. in more detail in future videos. Okay, so let's get back to this case that we introduced at the beginning of the lecture. So this is a 20-year-old male patient who presented with some abdominal pain, and there was an incidentally discovered mass on ultrasound that's being characterized on MRI. So there's no known history of cirrhosis and no known history of other malignancy. And on the MRI images, we note that there's no background liver disease either. So let's go ahead and characterize the mass and look at what it looks like on all of these sequences and try to figure out what it is. So we'll jump straight to the answers from this particular case. So the mass itself was T1 hypointense and contained no fat on the internet phase images. It was T2 slightly hyperintense to background liver. Post-gadolinium, it demonstrated some heterogeneous arterial hyperenhancement and was relatively hypointense on portovenous phase. This was a primovist study, and so the hepatobiliary phase performed at 20 minutes demonstrated that it was very hypointense to background liver. The mass also restricted diffusion. Notice that the mass has a central scar within it that was very T2 hypointense. And also there was note on the internet of phase images of this little focus of susceptibility artifact that was corresponding to calcifications that were better seen on the CT. So if I scroll down here, you'll see the calcifications better seen on CT within the scar. So this was biopsied and came back as malignant, namely a fibrolamellar HCC, which is an uncommon variant of HCC that, unlike most other HCCs, occurs in young patients without other risk factors for HCC. So in pathology in fibrolamellar HCC, the tumor cells are on a background of sheet-like or lamellar fibrous bands, so hence the fibrolamellar. And the imaging appearance in this case is typical of fibrolamellar HCC. So here we have a single large tumor with a central scar, and the central scar can make it difficult to differentiate from FNH, which is benign. Of course, calling this mass in FNH would be detrimental to the patient. But of course, there are a few key features that are going to help you differentiate FNH from fibrolamellar HCC that are covered in detail in the course. The most important and classic that we showed here are the central scar being T2 hypointense in fibrolamellar HCC. In FNH, it tends to be T2 hyperintense. The calcifications that we showed you on the CT within the mass. So calcifications are common in fibrolamellar HCC, but almost never seen in FNH. And the calcifications, again, are what caused the susceptibility artifact that we saw on the MRI in-phase images. And the mass was very hypointense to background liver on hepatobiliary phase. So of course, FNH is characteristically iso to hyperintense to background liver on hepatobiliary phase. Of course, if there are other frankly malignant features like invasion of surrounding structures, metastatic nodes, etc., we would think malignancy as well. Next, I want you to apply what you've learned in this video by taking the liver MRI cases in our liver MRI course, which includes all of the most important pathologies that you need to know, walkthroughs of imaging findings, and everything that you need to know about each case. So we cover how to characterize focal solid and cystic liver lesions, diffuse liver diseases, and some more challenging cases. And to access the rest of the course, visit our website at navigatingradiology.com. Thanks for listening, and I hope you enjoy the rest of the course.